Thank you for the excellent presentation. I know that you've already been welcomed to Missouri by Representative Franklin and Lichtenberger, but I'd be remiss if I didn't welcome you to Missouri again. We're very pleased to have you here, and on behalf of Governor Nixon, welcome to the great state of Missouri. Thank you for being here. I'm going to talk first about the extent of chronic medical illness among people with mental illness, and the extent to which, if you're interested in doing something about chronic medical illness, you're going to run into loads and loads of people with mental illness. You can't address one without running into the other. Then I'm going to give you some details on how we've approached health homes and care coordination and disease management here in Missouri. So to start out with a study of death rates in people with serious mental illness, we, in 2003, compared the death rate of people in the departments of mental health in 6 different states to the general population. The question is, do they have different rates of mortality? One way you can show rates of mortality is by calculating years of life lost. How much earlier, on average, did people die in one group as opposed to the other? So in the 6 states that were part of this study, Arizona, Missouri, Oklahoma, Rhode Island, Texas, and Utah, we looked at the years 97 to 2000 and compared people in their public mental health systems, enrolled in their departments of mental health, and calculated the years of earlier death. And on average, they're dying around 25 years younger than the general population. This means instead of an average life expectancy of around 78 years for a man, we're talking about an average life expectancy of down around 54, 55. People were surprised and said, oh my God, we didn't know suicide was that bad. So we did a cut on the cause of death. You can add up the total years. So in these studies, 1,800 people died, and that represented almost 48,000 years of potential life loss compared to the general population. About a third of those years were heart disease. Only 10% of those years were suicide. 10% of the deaths were suicide, less than 10% were accidents. The rest are general medical care. What people in public mental health die with is not suicide, they die of general medical conditions. This is a separate studies by Ben Druss and Dr. Dommett comparing life expectancy in people with no mental disorder to people with any mental disorder in the general population, going from about 75 to 80 years to just over 65 years, to the life expectancy of people with mental disorder in the public sector. My point here is this is an epidemic. This is the life expectancy of people in sub-Saharan Africa. This is the life expectancy that is shorter than people with HIV these days. This is the life expectancy shorter than people with HIV. This is particularly shocking if you look at the changes in mortality in the general population. Since between the 80s and 2000, one of the great public health victories in this country is vascular disease. Death due to heart attack and stroke has fallen by 50%. This is a huge victory that we don't celebrate enough. Other causes of death in the general population have stayed about even. If you look at people that have schizophrenia, during the same period of time, the red bars are death by cardiovascular disease, going up about double. And then the same with the white bars being all-cause deaths. So during a time period where the general population has vascular death dropping, other deaths staying even, people with schizophrenia are dying at increasing rates, both to vascular and other causes. It's getting worse, not better. So the first message to you is when you see somebody, when a healthcare system sees somebody with mental illness, the first question shouldn't be call the psychiatrist. The first question should be what's going on with them medically. You need to keep them alive long enough so they can talk to the psychiatrist. Maine did an excellent study of their Medicaid population where they compared the burden and frequency of disease of people with serious mental illness to people who did not have mental illness in their Medicaid system. The excellent part of this study is that it kind of controls for poverty. My epidemiology friends would point out that poverty is also associated with premature death, and people with mental illness tend not to have any money. They can't work and they're not as effective and productive, so they don't have money. But all these people were in Medicaid. None of them had any money. And for every condition, you see a higher portion of people with mental illness are burdened by that condition than people without mental illness. Congestive obstructive pulmonary disease, lung diseases, 28% compared to about 15%. Gastrointestinal disease, 33% compared to 20%. Some of these are not diseases that kill you, like skeletal connective tissue, mostly arthritis, but they are things that limit your ability to get around the community, to work, to interact, to have a reasonable life. People with mental illness have higher risk factors before I go on to the access. They are 3 times more as likely to be obese as the general population. About 60 to 66% of them smoke cigarettes compared to 20% of the general population. They are smoking at rates equivalent to the 1950s. If you are into public health and about smoking cessation, you need to know that 44% of all the cigarettes smoked in this country are smoked by people with mental illness. You cannot do an effective smoking reduction program without specifically targeting people with mental illness. Otherwise, you're missing the bulk of the population that you want to impact. Access to health care. One of the problems with our current healthcare system is we depend on the person that's ill to figure out when they need care and to pretty much know what to ask for also. This is particularly foolish in the case of illnesses that cause problems with memory, problems with concentration, problems with persevering. How many of you have difficulty obtaining your own medical care using your insurance benefit and find it somewhat arduous administratively? You know? It's not a smart way to organize and deliver, and if you have illnesses like depression, like bipolar disorder that interfere with your ability to organize and function, you're not going to be able to keep track of your on average 12 providers, your on average 16 different meds, and remember all the care you got from them so you can tell each doctor about all the stuff you got over the last year. You're just not going to be able, and it's not a good strategy for us how to organize. So, not surprisingly, people with mental illness, they overuse emergency and specialty care. They can't remember and keep their schedule together to keep an appointment 3 months out, 2 months out. They have lower rates of primary care. They have less rates of routine testing. I'll show you data. Here's the data on some of the routine testing. This is, I promise, is the most complicated slide I'll show you. But it's going to show you some of the problems with access to preventive care. This is a study that compared new antipsychotics to old antipsychotics, but they looked at chronic medical conditions. Metabolic syndrome consists of having 3 out of 5 conditions: being overweight, having high triglycerides, blood fats, having low levels of protective cholesterol, HDL is the good cholesterol you want more of, having high blood pressure, or being pre-diabetic or diabetic, poor glucose control. This slide compares people with schizophrenia going to academic clinics that can do research to the general population, which is the NHANES. It's a study done by the CDC every 3 to 5 years. So what this says is that for men, about 1 in 5 in the general population has 3 of these 5, metabolic syndrome, about 1/3 of men with schizophrenia. For women, it's 1 in 4 in the general population and 50-50 for women. Now let me tell you that metabolic syndrome, if you have it, you have the same risk of getting a heart attack next year as somebody that already has had a heart attack. People with metabolic syndrome have the same risk of having a heart attack in the coming year as somebody that's already had a heart attack. And look at the rates. 50% with high triglycerides, 50% with low levels of the protective high density cholesterol, almost 50% with hypertension, around 20 to 15% with glucose, with prediabetes. High rates of chronic medical illness. Why would you not screen and focus on these people if you have a 50-50 chance of finding them? And when they looked at whether they were getting treatment, of the 50% that had high lipids, 88% were not getting treated. Of the 50% that had hypertension, almost 2/3 were not getting treated. These are university clinics that do research that apparently are unable to identify and treat hypertension. This is shameful. This is not good care. 30% of the diabetics were not getting treatment. So one policy message that I want you to take home is that people with mental illness are a health disparities population. I want to deputize you all Dr. Collins with the CDC couldn't be with us this morning, so find her during the meeting and let her know that people with serious mental illness need to be a health disparities population. What does that mean? That means when you look at any health condition, you aggregate this group separately. We do that for poor Appalachian people. We do that for Native Americans. We do that for low birth weight babies. The policy move is if you're looking at heart disease, you should look to what extent it's driven by people with mental illness. If you're looking for diabetes, you should look at to what extent it's driven by people by mental illness. When we have two kinds of health homes in Missouri. We have primary care health homes statewide and FQHCs in some of our safety net hospitals. We have CMHC health homes. The percentage of people in the primary care health homes with diabetes is 15%. The percentage of people with diabetes in the CMHC health homes where they're all mentally ill is 30%. If you want to find diabetics, you'll find more of them at community mental health centers than in primary care clinics. Isn't that surprising? This also drives costs. This is from Meckel and Milliman. So the first blue bars show the per member per month costs of either private sector insurance, Medicare, Medicaid, commercial insurance, meaning private sector, running from about $350 per member per month up to just shy of $600 in Medicare with the older population, around $400 in Medicaid. If they have a mental disorder, they're much more expensive. And most of these expenses are not their mental health care. I'll show you that on the next slide. This is New York's Medicaid program. MH is mental health, SU is substance abuse, and then the third bar is having neither. Here you see the physical health care costs annually going from $16,000 for people with none of the other disorders up to around $21,000 if you have a mental disorder or substance abuse for just the physical costs. If you add on the behavioral costs, it makes it higher, but notice the point here is the orange bar is still bigger than the blue bar. The most expensive thing about people with substance use disorders and behavioral health disorders is not their behavioral substance abuse costs. It's their general medical costs. If you are about chronic illness and if you are about controlling and managing your medical costs, you're not going to succeed if you're not about behavioral conditions and substance abuse conditions, because that is what drives it. That is where you find those conditions, and those are the people you have to work with if you're going to reduce those rates and costs. So that's part of why we went to community mental health centers to be healthcare homes. Again, we have two different kinds of healthcare homes in Missouri. We have primary care practices and we have CMHCs. One of our theories is the practice that should be managing your care is whoever sees you the most often, because they have the most opportunity to make a difference and do something to manage you. People make more change by face-to-face interaction than they make by anonymous phone calls or letters through the mail. So whatever provider has the most face-to-face time in frequency and duration should be who's managing. For people with serious mental illness, it's by and large the community mental health center more than the primary care practice. As I pointed out, people die 25 years younger. 60%, actually 80%, I need to update my slide, of the premature deaths and years of life lost of people with serious mental illness are cardiovascular, pulmonary, medical. Some of the medications we prescribe tend to make people overweight, which drives a lot of the metabolic syndrome. And if they prescribe it at the CMHCs, they should be responsible for monitoring and addressing it. Community mental health centers have been doing team-based care since the 1980s. They've been doing treatment plans since the 1980s. They've been multidisciplinary since the 1980s. Much of what person-centered medical homes that's new for them and they're working on has been the nature of business at community mental health centers for a long time. What's new for them is taking care of the medical conditions in addition to the behavioral health conditions. We find that the things the CMHCs struggle and need to learn new skills at are different than what the primary care health homes struggle and need to find new skills with. They already have been providing individualized supports and services, referral to community, following up after discharge, checking on people's medication adherence. They've just been doing it only for the antidepressant meds and the psychotic conditions and the psych hospitalizations. Our transformation is having them follow up just the same with the antihypertensive meds, follow up just the same with the discharge after a heart attack. We also have been using health information technology a lot. Health homes is our fourth care management, care coordination initiative in Missouri. This is not the first one off. I'll say a little more about that. So the model we use is we do case management and facilitation of health care, and we use mental health case managers a lot. These are bachelor level people that have additional training that are supervised by the nurses, but much of what a health home needs to do in terms of reminding somebody to keep their appointments, checking on medication adherence, making referrals, following up on the results, that needs to be directed by a physician or nurse, but it doesn't have to all be done by a physician or nurse. So one advantage is having the mental health case managers who are paid for separately under the rehab option. They were existing resource already in place, and retargeting them to do this general medical work also. You're absolutely, you got the right information that primary care nurse managers are the secret sauce. The things that were transformational for us were getting the data and pushing it out to the providers. That was one. The second thing was adding primary care nurse managers. And we're now at the third thing, changing workflows and how people think. A word about how we push out data. One of our innovations in Missouri is most person-centered medical homes just work off of electronic medical record data. It's just what's in that one practice record. They create a disease registry, they track their data in the record. In Missouri, we use administrative claims. We take the payment records from Medicaid. Every time any insurer, including Medicaid, makes a payment, there's a diagnosis, there's a provider, there's a procedure, you know what meds they got when. They not only know what meds, I only know what meds I wrote at the clinic, Medicaid knows what meds got filled at the pharmacy. And I'm amazed that more payers don't take that information and make it available. People with chronic conditions see 12 to 20 providers a year. And it's really not possible to effectively coordinate and manage care if you only know the care you did in your clinic and you're depending on these 16 other practices or the patient to tell you about it, or you're gonna call up all 16 of them a couple times a year to find out what the heck's going on. It is silly for payers not to decide on their own and for policy not to require them to make that claims payment information the clinical part of it, not the dollar amount, but just the fact that there was a diagnosis, the fact there was an ER visit, the fact that somebody had a heart attack, available to whoever we're depending on to coordinate and do that care, which save them huge amounts of money. Why do health information exchanges only focus on getting electronic medical extracts when if you put the claims related data up there, you could get much broader information in many fewer databases? That's another policy point I'd like to make for you to consider. We have the CMHCs doing disease management interventions, things like diabetes education, smoking cessation in groups and individually with people with serious mental illness, primarily using bachelor level staff monitored by nurses and using manualized curriculum. They're screening for critical lab values like low density lipoprotein, triglycerides. We believe that care coordination for many people is best done by a local community provider. Well-organized people can get information over the phone, can get a letter, and will act on it. But there are many people that will not act on the basis of a letter from a company or the government, that will not act based on the phone call from a stranger. Many disease management organizations do phone banks. They call people up. But there's people that they really need to know who it is face to face. The difference here is the people giving the patient guidance actually go to their homes and meet them. The community mental health case manager will go to the home, do a pill count for the antihypertensives, just like the antidepressants, talk to them about what, you know, how they might smoke less, maybe they could walk around the block once or twice, and by the way, remember you have the appointment to follow up with orthopedic surgery next week. If they don't show up, they'll go get them. There are lower unit costs than nurses. A bachelor level care coordinator or mental health case manager costs about half what a nurse does, so you can deliver more life-changing personal interaction more frequently at a longer duration at a longer unit cost than you can relying solely on nurses. You have to have the nurses to give them guidance and the right information and target them, but you don't want the nurses doing everything. The nurses we've added are all primary care nurse care managers. For a long time, the CMHCs have made having people not homeless a major priority. We find that nobody gets good health care if they're living on the streets. If you're going to get them a good health care, you got to get them housed. So there are 6 required services if you're going to be a 2703 health home. You got to do care management, care coordination, transition of care, inpatient to outpatient, health promotion. Person-centered medical homes do all those. The 2 unique new services are individual and family support, helping people deal with all this, and referral to community services, meaning things like your heating assistance, your food stamps, all that other stuff that has to be taken care of before you can deal with your doctor visit and your other. And that's probably one of the major differences of a Section 2703 health home. One point I want to make also is Section 2703 is not a 2-year demonstration. It is not a grant. The state gets enhanced match, but does not get a lump sum of money to do this. They get enhanced match for the first 8 quarters, but the whole thing does not end after 8 quarters. It just goes back to the regular match rate. It is a plan amendment, a program of indefinite duration. It only ends if you decide to amend your state plan again. A lot of people think this is either a grant or a 2-year demonstration. That is incorrect. I talked about medication adherence and scheduling already. I certainly want to reinforce that this is not just a benefit, not just a program or team, it is a transformation of how you do business. Organizations that do health homes, person-centered, or 2703 health homes, or medical homes, need to do data-driven care and planned care. Most of the time when you go into an office, the physician will say, okay, what's bothering you today? And I'll attend to that, and then I'll try and think of anything else I know that you need to get on that visit. And it's kind of up to me to remember, up to you to complain. The thing about person-centered medical homes and health homes is they're kind of like a public health department at a clinic level. They look at the whole population, and that's a real change of thinking for practices. So instead of waiting for you to come in and then I'm going to look at your asthma, your diabetes, your heart disease, the health home will decide, okay, this month we're going to look at asthma. So I'm going to look at my data. I'm going to see everybody that has a diagnosis of asthma. They should be getting a thing called an inhaled corticosteroid that keeps you from wheezing to begin with. It's not a rescue inhaler where I do it after I start wheezing. And if you're not getting one, then I want to get you into your primary care doc and say, shouldn't Joe have an inhaled corticosteroid to stop him from wheezing? Asthma attacks are a major driver of ER visits. They also cause psychiatric problems. Why would not being on an inhaled corticosteroid cause psychiatric problems? Because then you're usually using your Alupent rescue inhaler, and you're using it like instead of 2 or 3 times a day, 12 times a day. About half the people don't use it right and breathe into their lungs. They swallow it at the back of their throat. And Alupent makes you nervous, jittery, and gives you trouble sleeping. So then you come to me, the psychiatrist, and you want a sleep med, and you want some Valium or Xanax so you're not nervous. And then you take those, but you still can't sleep at night, so you get up and now you're full of Valium and sleep meds and you fall down on your way to the bathroom. It's all connected. You cannot look at any of this separately. We found in our previous disease management initiatives, when we did messaging to improve psychiatric prescribing, mostly reducing people on multiple antipsychotics, multiple antidepressants, when the physician made the change recommended and reduced one of the psych meds, they also later usually had a reduction in one of the medical meds. You will not succeed unless you look at the whole thing all as one bundle. Actually, subcontracting risk, in my view, is a failed strategy. Why would you want the payer not to be at risk for all the care? If you give me the whole benefit and then you let me subcontract the mental health part here and the pharmacy part there, I don't have to worry and manage that anymore. I've subcontracted my risk. And I'm going to have a hard time getting data from my subcontractor. I think subcontracting, both the risk and also the delivery, is a questionable strategy. It's a good business strategy, but it's about managing your fiscal risk. It's not about managing the patient's care. Subcontracting is not about quality of care. It's about business risk. You should be suspicious of it. So we decided to try health homes, risks. If you never try anything new, you'll miss out on many of life's great disappointments. Our first disease management initiative in 2000 did not separate from the intervention was no better than care as usual. The first time we tried this stuff, we didn't get anywhere. The second one worked, the third one worked better. We're thinking we're going to get better outcomes on this next one. It's important to try new things, and I always feel if I'm not failing 20% of the time, I'm not trying enough stuff. We've gone over the difference between health homes and individual care and treatment as usual. In the interest of time, I'll go ahead. For Missouri, here's the difference between our health home populations. In primary care, it's either diabetes alone, because that puts you at risk for other conditions, or two of any of these, being overweight, using tobacco, cardiovascular disease, asthma. We've included developmental disabilities because they're fragile and have complicated care. We just thought they needed the extra help getting general care. At the community mental health centers, it's people with a serious mental illness or some other mental illness or substance abuse problem plus one of the above. Basically, anybody that goes to a CMHC is eligible. But we did not enroll everybody. Everybody's eligible, but we enrolled in each case the high utilizers. We did auto-enrollment of people that had utilization in the previous year of greater than $10,000 and were not terminally ill as indicated by things like hospice claims, dialysis claims, high-stage oncology. So part of what we did is we did not let the providers decide who was going to be enrolled initially, because how are they going to know who uses the most care? The payer knows that. Now, they can pick out other people and add them one at a time, but we did fill up their capacity with the highest utilization people because you can't save money unless you're already spending money. Here's the rates of health conditions, and asthma COPD, 34% in primary care, 25% in CMHC. And this is a little different than some of the earlier levels. We think we're underdiagnosing and that our screening is going to push this up over time. The health home responsibility on the primary care side, they all provide primary care, but in most cases, the CMHC health homes do not provide the primary care. They are a wraparound service for those small and medium primary care practices that can't do care coordination, that don't have the data aggregation and management capability, that don't have the patient teaching and patient support. But some things are identical. Coordinate hospitalizations both do, avoid inappropriate ER both do, managing chronic health conditions, promoting healthy lifestyles. On the primary care side, we have 18 FQHCs and 67 clinics, 5 hospitals with 22 clinics and 14 rural health clinics. We have currently enrolled about 15,000 people. At the CMHCs, we have 28 CMHCs at 120 different locations, and we have about 16,600 enrolled at any given point. One other difference between person-centered medical homes is, in general, it is a capitation payment. It's a payment for an eligible person to a designated health home, irregardless of whether they do something with them that week or not. On the Section 2703, CMS in its wisdom, although the federal statute said it can be capitation, they actually run it as a case rate. They cannot be paid unless they actually do something, and it's not everybody. The CMHCs, that's only about a quarter or 20% of the total people they serve. So the per member per month is higher because it's paid on the basis of a smaller number of people. If it were a person-centered medical home, we would give a smaller payment for everybody, but they would focus all their efforts on the smaller number of people that were more complex. That's part of the reason to the gentleman's question of why the rates are so different. The person-centered medical home is a small payment for everybody eligible. The health home is a larger payment, but not for everybody. It's only for the sickest, most intense people. It's a choice of payment methodology. The net dollar volume could well be close to the same. So in Missouri, we've added a couple key different staff. The CMHC health homes and the primary care have a nurse care manager for every 250 people. This is a primary care nurse that doesn't do direct care, but manages, coordinates, identifies care gaps. I'll talk a little about how we do that. They have a health home director, more at the CMHC than primary care. This was noted previously is a big administrative lift. Practices have to give data back. They have to take data in and use it. They have to have MOUs with hospitals. They have to have relationships with other providers. If you're going to change the way you do all your internal work, you have to have a manager responsible for that. And that's the health home director. It also gives us a single point of accountability as the state manager. They're responsible for overall daily operation, enrollment, discharges. They may serve as a nurse care manager. Most of our health home directors are nurses, and in the smaller health homes, they also carry a caseload. And the bigger, it's their only job. NCM is nurse care manager. We track their use of our health information technology tools. They do MOUs. The nurse care managers are responsible for identifying care gaps, but they also do an annual risk screening on everybody. They participate in the treatment planning. The mental health treatment plan, which used to be solely about your mental illness, your ability to relate to others, your ability to live in the community, now includes issues related to your general medical care, your diabetic education, physical activity. They consult with the community support specialists. These are the mental health BA level workers in the community, and target them on what to work with. You know, we see that John's blood pressure is high. We looked at his pharmacy records. He's not filling his antihypertensive all the time. Go check on John and help him get his antihypertensive filled and get him a pill box so he can take it. This is, again, how you use data. You can look at everybody with high blood pressure. Some of them aren't getting an antihypertensive at all. They need to go to primary care, get one. Others are getting it, but they're not taking it regularly because they're not filling it. That's a conversation with the patient and getting it filled. So the data needs to be used, and the nurse care managers are responsible for this to target the staff to take care of the specific problems. Each of the community mental health center healthcare homes have a primary care physician consultant. We shouldn't be managing a bunch of medical conditions without a primary care physician backing the team up. They're there to consult with the nurse care managers, with the psychiatrists, with the other people in the mental health setting. And the rest of the usual mental health team is still there. The psychiatrists, the therapists, the community support workers, the psychosocial rehab. That's where a small group teaching setting. We used to work on socialization. We still do. Now we also do diabetic education, weight loss intervention. It's truly about the whole person. But instead of having a nurse be the only one that talks to you at about $100,000 a year total cost about increasing your physical activity and your diet, we'll have a trained BA overseen by a nurse with a manualized curriculum doing it at half the unit cost. We measure a lot. What gets measured gets done. Care management, I've talked about how we use the claims to identify care gaps. Do you have asthma? You're not getting the inhaled corticosteroid. We can make a list of people that need follow-up on that. I won't go over that again. And again, our innovation is using the administrative claims in addition to the clinical value. I think at the end of the day, we need to be using both clinical records and our administrative databases. So we get the historic claims, we add clinical values like blood pressure, height, and weight, some lab values, we combine it into a searchable registry, and it's online available to all providers. It's a web tool, and the health homes can log in and see their patients, manipulate their data. We've been doing this since 2010. I talked about the gaps. Giving an example on the inhaled corticosteroid, when we focused on that for 2 quarters, we were able to reduce the percentage of people not getting the recommended med by 45%. You know, if you target specific small actions, it's not about getting all 20 steps on the asthma algorithm right, it's about getting 1 or 2 common gaps that occur at high rates. Care coordination is the second service required of health homes. Coordinating care between multiple providers, planning hospital discharge, communicating. We actually require and retrain the health homes on HIPAA. Most healthcare organizations overinterpret HIPAA. They are overly restrictive. They think you can't share any information without consent. HIPAA actually allows sharing of health information between people that are known to be treating the person absent patient consent. You do not need patient consent. If I know that you're the primary care doctor and you know I'm the psychiatrist, we can share information without doing all that paperwork back and forth. We've been actually providing an electronic health record where providers can see all the care a patient gets in Missouri. It's called the Cyber Access since 2005. A Medicaid provider can look up all the care their patient's getting and see what other meds, who is doing it. Virtually no complaints from the patients. And when you ask them about that, they say, well, why weren't you talking to each other before? I expect that. One other innovation we've done is the health homes all get overnight notifications of new hospital admissions. This is, again, a payer-driven initiative. We don't do it through the hospital. You may have noticed whenever you go to the hospital, they ask for your insurance card. That's because the insurance requires them to call immediately and get agreement that they'll pay. So you show up at the hospital for depression or pneumonia, and usually within an hour somebody's called up and says, Joe has depression or pneumonia. You said, okay, we'll pay for 3 days, click. And they put it in their database. So Medicaid at their initial authorization of stay deaths knows within an hour or two of everybody's hospitalization. We take that data and automatically email it once a day out to the health homes. We sort it out. We link the person to the health home, we scan the list for anybody in a health home, and we automatically send out, say, hey, Joe got admitted a couple hours ago. You ought to go check on him, coordinate care. I don't know why other payers don't do this. All the other commercial payers could. Medicare probably should, but everything's retrospective there. That's another problem. Don't get me started on that. I'm going to show you some outcomes now. First, I'll show you one of our the initiative previous to this, the CCIP program, and then I'm going to show you some very early outcomes from our health home program. In this earlier program that ran 2008 to 2010, the average person in the chronic care improvement program, which was a joint primary care CMHC, the CMHCs did 10% of the cases in the chronic care improvement program. The other 90% were primary care. We had about 25,000 people between 2007 and 2008. About 40% had asthma, about 70% had coronary artery disease, another 20% had congestive heart failure, 50% with diabetes, about 1/3 with behavioral. Pretty sick group. One thing, if you're going to do these, preventive care is great, but you need to focus on the sick people and help them from getting sicker. Using the kind of mechanisms I described earlier, this program was able to increase the rate of screening for diabetes. If you're diabetic, you should be getting your hemoglobin A1C, a measure of your glucose control, checked, doubling it from 25% to 40%, 47%. They got 1 testing a year, 2 testings a year, so this is an indicator of better quality of care. When we do these programs, we want to both look at quality and utilization and cost. It's not all about one or all about the other. And I'll show you a little about cost in a minute. People with coronary artery disease should get their lipids checked. This program was able to double those rates from 20% getting 1 or more tests to 40%, and 7% to 14% getting 2 or more tests. Let me show you what it did for cost. This is ER usage rate in the chronic care improvement program. The yellow line shows that they were getting on average 250 visits in the ER per 1,000 per year in the baseline period, going up to when this program started in 2007. The blue line are people that went in the program. The purple line is people that are the control group that did not go in. So a nice reduction in lower ER visits in people that got this kind of follow-up, data feedback, nurse care coordination at a less intense rate than health homes. Total spend, the big question, the money. The average cost was going from $1,200 per person per month. These are people that were costing $24,000 to $30,000 per year. This is a deep end program of people using a lot of services. Dark blue line up to the point of intervention. This program enrolled the sickest people, so the non-intervene group immediately looks cheaper because we skimmed off the sicker people. But you see the intervention group trending down and the non-intervention trending up to the previous trend for a spread of about $300 per member per month savings in this program. This program, say, broke even at about 18 to 24 months. 18 to 24 months in, it was saving the cost of the intervention. However, when we did a separate analysis of the community mental health centers, they actually were saving 16%. The community mental health centers were doing better as the program than the program as a whole. Why would that be? Number one, the people in the CMHCs were sicker and more expensive to begin with. The more expensive the person, the more opportunity you have for savings. This is again the point of you want to go to the agencies that have the highest density of high utilizer illness if you want to make savings. Number two, the primary care practice didn't have the boots on the ground. They didn't have people that could go out and do the home visits. They didn't have the BA level people. They were just given resource for the data analytics and the nurse care managers. And at the CMHC, we redirected and piggybacked on our existing care management resources that we've been using for mental health care management since the 1980s, that community mental health case managers. So we're able to send people in the homes, we're able to get face-to-face with them, we're able to have face-to-face interaction more frequently, of longer duration with people that were sicker to begin with. The primary care practices really need to be given staff like this. It really hampers their ability. They're stuck doing things just in clinic. They can't go find people when they don't show up. Here's some of our healthcare home outcomes. Now, I want to reiterate what you heard previously. This is data just 1 year in. Everybody will tell you that you need multiple years to really evaluate these programs. Mercer has warned us again and again that we shouldn't be quoting any cost savings until we're 2 or 3 years out, but people insist on seeing some early results. So what I'm going to show you, I want to tell you the next time I present this to you, the numbers will be different because they're being redone constantly. But we are seeing reductions in hospitalization. We started January 1st of 2012 for primary care. We have a nice 7%, 8% reduction. And for CMHCs, going from 33% down to 24%. Notice, of course, the people with the CMHCs are going to the hospital more already. They are the sicker population. Our initial estimate, and this is our initial estimates, you're going to see different numbers. This is from the spring. We're recalculating our fall numbers, which Mercer tells us is still way too early to quote. We're going to do our best anyway. But we are seeing both hospital savings and ER savings ranging in the 7 to 14% range, which for the group we currently have should be around $1 million to $4 million. And that's just hospital and ER. We haven't looked at all costs, and we add everything in, it'll change some. Medication adherence is improving over the year. We're getting adherence to psychiatric meds has risen by about 3–4%. Cardiovascular med adherence is better. We focused on asthma COPD, so we've gotten a few percent better on that also. I talked about the increase in people on controller medications. That's the inhaled corticosteroid that keeps you from wheezing to begin with. We also have about 15% in the health homes are children. Hospital discharge coordination. We are up to about 70% follow-up of people within 72 hours. We're contacting about 70% of the people within 3 days of leaving hospital. We're convinced that the sweet spots here are medication adherence, meds only work when you take them, and getting to people right after hospital, because you know when you leave the hospital, you're not listening to all that stuff they tell you. You just want to get home, and you miss a lot of it, and then you don't feel good, so maybe you didn't fill that script, and you didn't really understand you're supposed to stop this other med, so now you're taking your old med and your new med when you're only supposed to take the new med. Follow-up rapidly after hospital is one of our key targets. Depression screening, this is a requirement for the primary care health homes, and they're doing better on that also. Follow-up screening and following up for substance abuse as a primary care health home. This again is to reinforce the point that this program requires integration. The primary care health home gets a behavioral health consultant instead of a primary care consultant to be their internal expert. We've had an outside evaluation by a different group that came in to do a learning collaborative. They report that we're doing better on hemoglobin A1Cs, on blood pressure, on LDL, more quality measures. I'm sorry that I've gone a little long. I'll end by saying a little about what makes it possible. You talked about it being a public-private partnership, and it really is about the relationships. You know, in Missouri, we were the first to get approved. The only one that implemented before us was Rhode Island, and we're often asked to advise others. And they always ask about how do I structure the rate? How do I do the data analytics? And I always tell them, first you have to develop the working relationships. Department of Mental Health works very closely with our state budget office and Medicaid. We're in all of each other's meetings. I see the Medicaid people 2 or 3 meetings a day. And we use our provider association, the Community Mental Health Center and Primary Care Association, as management staff. They are actually co-managing. They co-built it with us. They co-manage it with us. We're short on staff. I need the extra staff they were doing the work. I was happy to give them work. I'd like to give them more. We are transparent with our use of, we benchmark them against each other. Every CMHC and primary care practice can see how they're doing compared to all their cousins. I really want to thank both the legislature and the budget office for willing to take the risk and let us take a fly at this. You know, if you don't try anything new, you don't get anywhere. Funding the nurse care managers and the IT platforms were the 2 key resource issues. It's taken a huge amount of training. Don't underestimate the amount of training. We have a couple conference calls with either nurse care managers, health home directors, management team. We've done both regional and statewide trainings, ton of training to get people to change. You've seen that slide. I'm going to end with an inspirational slide, change. When the winds of change blow hard enough, the most trivial things can turn into deadly projectiles. Does healthcare reform feel like this sometimes? So the question is, where do you want to be in this picture? Do you want to be the thing that's hit by the projectile? Do you want to be the projectile? In Missouri, we're trying to be the wind. Yeah, and my advice to you as policy people is to figure out how you can be the wind instead of the projectile or the thing hit. Thank you very much.